All right, good morning. Good morning, everybody, and welcome to our July Hot Issues in Health webinar. We are going to get started in just a minute. It is right at 8, so we know everyone is quickly grabbing their coffee and getting into a comfortable chair while we get started. Let's see here. We are going to be talking today. We are very excited. Our theme for today is CHASapalooza. We are focusing on some recent issue briefs, some data briefs from the Colorado Health Access Survey with a friendly nod to everyone's favorite summer music festival. Again, you have joined CHI's Hot Issues in Health webinar. My name is Sarah Schmidt. I'm the president and CEO of the Colorado Health Institute. And I'm actually joining you today, this morning, live from CHI's brand new in-office media studio. I think if you follow us on social media, we might have put some photos up, but I cannot tell you what our top-notch communications team has done to pull this together, all in the service of providing all of you, our partners, with engaging and high-quality content. So we're really excited. Things are going to look a little different today. We will be monitoring chat in some different ways, but please go ahead and get started, get warmed up. Maybe type your name and the organization or the community that you're joining us from in the chat so that everybody who is online knows who they're hanging out with this morning. All right, if you are not familiar with CHI, we are an independent nonprofit public health institute. We have been providing trusted data, independent research, and fostering collaboration to advance health and equity across Colorado. We have been privileged and honored to do that since 2002 and are grateful for all of the opportunities to work with all of you across Colorado. And if you've never worked with us before and you're interested, please reach out. We'd love to partner with you. Today, I am joined by two of my colleagues for our presentation. My colleague, Christy Ariano, our Managing Director of Marketing and Communications, and Vianney Bermudez, our Communications Manager. Before we get started, just a couple other people who are really important to today's presentation. First, our Communications Director, Joe Hannell. He worked tirelessly for days on end to pull together this tremendous studio that we are in today. So thank you, Joe. I also want to acknowledge our Communications Specialist Manager, Deanna Geldens, who actually wrote the data brief on oral health that I will be presenting today. So Deanna is responsible for all of that excellent analysis and content. And lastly, just a shout out to our analysts and our data managers who supported all of us in pulling these data together from the CHAS. Many of you who have, if you've used the CHAS, you've probably worked with one of them before too. So we're really fortunate that we have people here who can do really smart data work. Right. So speaking of the CHAS, so the CHAS it's a statewide resource. It is an asset that is available for all Coloradans. At CHI, we are proud to be the steward of this resource, and we are grateful for the trust that you all place in us for the work that we do on behalf of the survey. All right, so exciting. 2013 marked a birthday for the CHAS. The CHAS turned 15, and it has really been that go-to source of trusted data for communities, for journalists, for state and local policymakers, for foundations, really to individual Coloradans for the last 15 years on really important and critical issues that help us understand health. Since 2009, this fully representative 10,000 household survey has been tracking really important issues such as insurance rates, use and access to care, and barriers to care on these issues that we like to call evergreen. But at the same time, the CHAS has been flexible, we are nimble with it, and we've been able to add new questions over the years, really in response to the questions and the needs that you all have shared with us. So for example, now the CHAS includes data on social factors such as food and housing. Also, Coloradans' experiences accessing care. And we are here today just to ask for some insight and input from you to help keep the CHAS going. So every year we are always talking with our private philanthropic partners and state agencies to raise resources to ensure that we can put out the CHAS, that we can conduct another survey. And we are very grateful to them for their support. That allows us to make all of these data free and available to all of you, to all of Coloradans. And so if you are one of those funders, we are grateful for the funds that you've given us to do previous CHASs, and we hope that you will support us in 2015. We also, though, want to hear from all of you and know how you are using the CHAS. That helps us be able to then understand its value and then make sure that we are communicating that value with those who can help us sustain and keep the CHAS going. So on your screen, you see a little QR code. If you could take a quick minute sometime today and just take a picture of the QR code, it'll drop you into a survey. Just give us a little feedback on why the CHAS is important to you and how you use it. All right, almost getting to the good stuff here. If you have not checked out our website, please do take a look. We have been, since the launch in February of 2024, putting up data briefs almost every few weeks. Topics such as mental health, LGBTQ plus health, housing, long COVID, and there's many, many more up there. So please do take a look. We're going to highlight just 4 on today's presentation. We will talk about telemedicine, substance use, reproductive health, and oral health. We will highlight these briefs. We will be sure to leave plenty of time for questions and discussion at the end. And with that, I'm going to actually physically hand off a clicker, which is kind of exciting, to my colleague, Christy.
Thank you, Sarah, and good morning, everyone. Thank you so much for joining us. The first topic we're going to dive into today is telemedicine. And it's a great example of what Sarah was talking about how the CHAS is responsive to emerging needs. Prior to the pandemic, the CHAS didn't ask about telemedicine. Why would it? It wasn't on anybody's radar. But in a very short time, much like we all got a crash course in Zoom, we got a crash course in telemedicine. So we added a telehealth question to the CHAS in 2021. And in 2023, we kept that question on there because we were very interested in learning what changed over that 2-year period. Was telemedicine just a flash in the pan, or was it something that fundamentally is changing how we receive healthcare? So before we get to the data, I'm going to ask you to put into the chat whether you think overall telehealth use increased or decreased between 2021 and 2023. I'll let you type in your answers. So here we see 2 donut charts representing 2021 and 2023. The darker orange segment is those who had an appointment with a doctor, a nurse, or another health professional by video or phone in the past 12 months. And we see that the use of telehealth did drop some, but not by much. It went from just over 37% in 2021 to just under 35% in 2023. But that's still a big portion of healthcare. But what's more interesting, at least to me, than the overall use might be the shifts we saw in what types of service people were accessing through telemedicine. We asked respondents who had used telemedicine what their most recent visit was for. The orange bars that you're looking at show 2021, the green are 2023. It is worth noting that about half of the respondents said their most recent visit was for primary care, but that percentage did dip over the 2-year period. More striking might be the increase in mental health care visits, which are those bars in the middle of your screen. That jumped from about 17% in 2021 to 29% in 2023. And that makes sense if you think about it. Mental health care can lend itself more naturally to the video or phone consultation due to the fact that it's much more conversation-based. The doctor doesn't need to look in your ear or listen to your heart rate. So now let's talk about the people who didn't use telemedicine. Once again, the orange showing us 2021, 2023 is in green. The top 3 reasons that people didn't use telehealth care was that they would rather go in person, they just didn't need health care, or their healthcare needs couldn't be taken care of by video or phone. I also want to highlight a few other reasons that didn't rank nearly as high, but still showed up as responses. And those included technology challenges, lack of privacy, and concerns about confidentiality. Even though these were relatively small numbers, they represent real barriers that need to be addressed if Coloradans and their providers are to truly benefit from telemedicine. And even among those who did use telemedicine, it didn't always go smoothly. Coloradans who used telemedicine in 2023 reported challenges with communication, with technology, or with privacy. Respondents could report more than one challenge experienced, and the types of issues they reported varied. About 1 in 13 who used telemedicine said it was difficult to use the portal or app. Another 7.4% said they just didn't get clear instructions from their provider about what was supposed to happen before, during, or after the appointment. This represents a need for providers to simplify their guidance and technology, and to create opportunities to train users or troubleshoot their issues before an appointment begins. So what can we take away from all of this? Telemedicine has the potential to increase access, especially for certain types of healthcare, like mental health. But to be truly effective, patients need more education and communication from their providers. And although telemedicine has potential, it's just one piece of the puzzle. Many patients still want or need in-person care. What we know for sure is that the healthcare system must embrace flexibility to ensure that patients get the right care in the right medium. And with that, I'll hand it back to Sarah to talk about substance use treatment.
Thank you, Christy. Okay, I'm back and I'm going to share data on Coloradans' need for and use of substance use treatment. So the CHAS asks about, again, as I said, Coloradans, do they need substance use treatment? Did they seek or did they receive treatment? And what were some barriers to accessing care? These questions have been included on the CHAS since 2021. And the data that I'm going to show today combine both the 2021 and the 2023 survey so that we can provide reliable estimates to show. So with that, nearly 100,000 Coloradans said that they needed substance use treatment, but they did not get it. At the same time, we know from other data sources that about 1 in 5 Coloradans report drinking alcohol excessively. And similarly, we know that in 2022, we lost more than 1,800 Coloradans to a drug-related overdose. So while this 100,000 number stands on its own and is important for us to be thinking about and addressing as a state, we suspect that it might be an underestimate. First of all, this represents only those who are willing to share in a survey that they need a treatment, but were not able to get it. And we also know that people may be in different stages as to whether they feel that they need or are ready to seek treatment. So there's a lot going on this slide, but it shows the reasons why Coloradans did not get needed treatment. So I'll give you a sec here. You see those reasons that are on the one side of the slide, and then the percentage of Coloradans who said that that was the reason. And again, they could select more than one reason, so they won't add up to 100. I'll draw your attention to the bottom, actually, of this slide. The most common reason, nearly 2/3 of Coloradans did not get needed treatment because they didn't feel comfortable talking with their health professional about this need. Just over half, second most common reason was around cost. And then the third was that they were concerned that someone would find out that they had a problem. Now, it's interesting, I will juxtapose these data, these findings, with what we learned on the 2023 CHAS as to why Coloradans did not get needed mental health treatment. And actually, you'll find this on our website, it's almost the inverse. So the top cited reason why Coloradans did not get needed mental health treatment is because they couldn't get an appointment when they needed it. So that was the most common reason. And those issues around comfort talking to a health professional was the 4th cited barrier. So I flag that only because it's a unique insight. We often talk about behavioral health, And we put mental health and substance use together when we talk about behavioral health. But the CHAS is able to provide us with some valuable insights that show that there's actually different reasons, or there are different barriers for Coloradans seeking these types of care. So this slide looks at two of those barriers, but differences between rural and urban Coloradans. So it looks at those that comfort talking to a health professional, that's that top bar, and then concern about someone finding out. Urban Coloradans are represented in the blue bar, rural in the yellow bar. And you can see that it's about the same percentage of urban and rural Coloradans report discomfort talking to a health professional. But where we really see some differences between our rural and urban Coloradans is around that concern about someone finding out. And we're referring to that as stigma on this slide. You see almost a 20 percentage point difference, actually over, if I'm doing my, it's a little early, I need to get my math going, over a 20 percentage point difference in terms of rural Coloradans versus urban. So different concerns that we're seeing in rural areas. This slide delves into one of those barriers around concern that someone's health insurance would not cover treatment, but looks at it by income. So just about 44% of all Coloradans were concerned about insurance covering it, which is why they didn't get needed substance use treatment. But we see some differences by household income. Most specifically, that our middle income Coloradans, those who are earning between 139 and 400% of the federal poverty level, are more likely to report this insurance coverage as a concern. You see over 50%, 55.7% actually. When we look at our lower and our higher income Coloradans, they're slotting in at, they still report that as a concern, just about 40%, but slightly lower. And again, 40% is not an insignificant barrier, but lower than over half. I want to just point something out. It's unusual that we see similar rates among our lowest income and our highest income Coloradans. And so while we don't know for certain that everyone who is under 139% of the federal poverty level is enrolled in Health First Colorado or Medicaid, it could potentially be a nod to some of the work that the state has done over the last several years, really expanding the full continuum of substance use treatment benefits for those who are enrolled in Medicaid. All right, so what comes next? What does all of this mean? Well, the first is that we have to all get comfortable talking about it. We have to get comfortable both as individuals, as patients, but also as providers. Asking questions and being willing to talk about whether we need substance use treatment. And then secondly, all of us need more information about what does our insurance cover, and how much will that cost, and what can we actually be seeking in terms of needed treatment and care. And I'm going to now hand it over to my colleague, Biani.
Thanks so much, Sarah, and good morning, everyone. Today I'm going to be discussing the critical issue of disparities in access to contraception here in Colorado. So let's delve into the data from the 2023 Colorado Health Access Survey, which actually for the first time included questions on reproductive health, which I find really exciting. This new insight into birth control trends among Coloradans is crucial for understanding systemic barriers to contraception access and promoting sexual health awareness in our communities. So let's get started with this first data point. We were looking into a few Coloradans talking to their provider about contraception. So like Sarah was talking about earlier, getting comfortable having those conversations with a healthcare provider. The survey asked whether respondents had received counseling or information about birth control from a doctor or healthcare provider in the past 12 months. In this graph, you can see that out of the people surveyed, 51.2%, so that's going to be that gray bar, didn't need or want to talk about birth control, marking that question as not applicable. And in the red, we can see that 12.1% talked to a doctor about birth control. And in the yellow, we've got 36.7% that didn't talk to a doctor about birth control. So for those who did answer the question applicable, about 1 in 4 Coloradans actually talked to a healthcare professional about birth control in 2023. Within that, we broke it down by gender because we found a huge gender difference. by these demographic groups. Men were significantly less likely than women to receive information or counseling about birth control. We know this disparity may stem from societal norms and assumptions about men's reproductive health responsibilities. And then we delved a little bit deeper into noticing a disparity in race. We found that Black respondents were less likely to get birth control information compared to other race or ethnic groups, with Hispanic or Latino populations having the highest rates of birth control counseling or advice from a doctor or healthcare provider. So now we're going to dive into the access and the barriers that people have experienced getting the birth control that they wanted. And some of these barriers included insurance coverage issues, cost concerns, and limited availability of appointments. As you can see, the birth control options that cost too much and insurance did not cover are our top two reasons that people could not get the birth control that they wanted. And another huge barrier that we found was actually language barriers in access to birth control. People who speak a language other than English were 3 times more likely to encounter challenges to accessing the birth control that they wanted. And we know that language barriers hinder effective communication and access to essential services like contraception. 10.7% of the people who didn't speak English at home could not get the birth control that they wanted, compared to 3.3% of people who speak English at home. So what's next for reproductive health? Despite having the availability of counseling, there's significant disparities persisting in both counseling and access to birth control and reproductive health, particularly affecting non-English speakers, uninsured individuals, and Coloradans of color. Sexual health, though a significant factor to overall well-being, often isn't at the forefront of health conversations, and it's significantly harder to get for some people. After analyzing this data, we're left with a few questions. What systemic changes do we need to eliminate barriers to contraception? And how can we ensure equitable access to reproductive health services for all Coloradans? Comprehensive reproductive health education tailored to diverse demographics is essential for addressing these disparities. But the good news is that now we have a starting point for data trends in reproductive health in Colorado. And with your help, we can definitely continue to ask these questions, collect more data, and track Colorado's progress in the reproductive health space. And with that, I'm going to hand it back to Sarah to talk to us about oral health.
Thank you, Biani. Oh, wait, sorry, going back. Sorry. Okay, well, hey, 3 of 4. There's a lot of data going on this morning, and it is way early, so thank you for hanging in there. This is our last one before we get into some Q&A. Hopefully, it has just made you all the more excited to go to our website and dive into some of these issues a little deeper. I'm going to bring us home with oral health. It is a very important part of overall health. I'm so proud that the CHAS has included oral health questions on it since 2013. And really, these trendable data have informed state and local policy and practice changes that we have seen happen over the last several years. So I'm excited to share what we found in the 2023 CHAS with you on oral health. We're starting big picture and just looking at how are Coloradans faring when it comes to oral health. I'll direct your attention to the top bar here. In 2023, we found that nearly 1 in 5 Coloradans, so that's almost 1 million of us, reported fair or poor oral health, and that is in that green part of the top bar chart, 17.6%. Now, one of the benefits of trendable data is that we know what has changed over time, and unfortunately, this percentage has not changed significantly since 2013. We have historically always had about 20% of Coloradans reporting fair or poor oral health. If we drop down to that second bar, we see a smaller percentage of Coloradans, about 5.8%, reporting severe oral pain. And that's about, to put it into numbers, about 330,000 Coloradans. Now, again, that's a smaller number. However, if any of you have experienced any type of oral pain, you know that it's debilitating. And so while it's small, it's a significant number for us to be tracking as a state. Right, so before I put data up on the slide, I just want to share a little bit about who's getting care, who saw a dentist or a hygienist in 2023. And we found that about 25% of us did not see a dentist or a hygienist in the past 12 months in 2023. Now, the inverse of that means that about 3 in 4 or 75% of us did. And for some good news, that's actually an increase. We had a decrease in oral health utilization during the pandemic in 2021. And so we saw a bump back up in 2023. So we're glad to see, and yeah, in 2023. So we're glad to see that change. I will say though, that not everyone was using oral health care at the same rates. So we saw differences as it related to insurance status or age or race and ethnicity. I'll give just a little bit of data up here on the slide. So these shows the differences in use of, in lack of use, did not see a dentist or a hygienist by language spoken at home. And you see that 37.9, nearly 40% of Coloradans who do not speak English at home did not see a dentist or hygienist last year, whereas we see a lower percentage, 23.7, who do speak English at home. If you're curious about some of the data and those differences, check out the website. The data brief has a lot more data on differences in terms of use of oral care. Right, so now we're going to pivot and look at why people didn't use care. So we asked people why they didn't get needed care, and cost is the most commonly cited reason. About 17.2% of Coloradans who did not get needed dental care cited cost. And it typically is the most commonly cited reason that we have seen over time, truly, in terms of why people don't access care. But a couple others that kind of rose to the top, about just under 10% cited fear of pain, and about 8% didn't get care because they didn't feel like they could relate to their provider, to either their dentist or their hygienist. But there's other reasons, and we show a few of them on the screen here. So about 7% of Coloradans didn't understand their dental benefits or their benefits. And so it's partly what kept them from seeking care. Also still some fear of COVID is out there among Coloradans. And then we see some access related issues. So office not taking patients or transportation, or just not having a provider near them. Again, smaller percentages, but still barriers that keep people from seeking care. Now, before we wrap up on our data and bar charts, I just want to take one more slide to dig into that top benefit around, or that top bar, not understanding benefits, and just see how that differs by particular insurance type. So we have looked for the last few CHAS cycles on how that response varies based on those who are enrolled in Medicaid and those who are not. And we still we've seen in the last few CHAS cycles a difference in terms of those who are enrolled in Medicaid are 3 times as likely to report not seeking needed dental care because they don't understand their benefits compared to those who are not enrolled in Medicaid. We flag that, take a look at it, and track it because, again, similar with substance use, the state has done a lot of work, and partners across the state have done a lot of work really ensuring that there is a robust dental benefit for both adults and children for those who are enrolled in Medicaid. And so this feels like an opportunity to help people understand their benefits and access care. Right, so what comes next? What does all of this tell us? Some things to be tracking. Well, first, let's try to move that needle in 2020 on the 2025 CHAS and help all Coloradans achieve good oral health. Let's lower that percentage of those who are reporting fair and poor oral health. We have good evidence-based dental practices. Let's make sure people can access them. Secondly, we saw that increase in those using care, and let's maintain that post-pandemic momentum so that people can get needed dental care either with a dentist or a hygienist, which means addressing some of those barriers that have come up for folks. So lowering cost, addressing some of those access concerns in terms of finding a provider or relatability with their provider, and then of course helping folks use the benefits that they have. All right, with that, before we pivot over to Q&A, I want to take a minute to just give a big shout of thanks to our sponsors for the 2023 survey. So the Colorado Health Foundation is our primary sponsor for the 2023 survey. And you also see, though, that we have many public and private partners who have also supported the 2023 survey. So if you are with one of these organizations or agencies and you were on this webinar today, thank you. If you work with any of these organizations or agencies and you use the CHAS, please thank them for their support. And with that, we are going to move to a different camera angle and questions and answers. Here we go.
All right, thanks, Sarah. I'm going to take you from here and I'm going to be reading some questions from the comments. So I'm going to ask my colleagues if you have any questions in the Q&A section and put those in the comments, please. And our first question is actually for Sarah.
Would you? Sorry. Live.
Is there a provider issue with oral health?
Question, is there a provider issue with oral health? So I think from the data, we know, if we even just look at the 2023 data, there are certainly a percentage of Coloradans who say that there was not an office in their community. So the answer is yes. If that percentage was 0, then we could answer differently. CHI has in the past done some provider analyses looking at where providers are located, counties that maybe don't have providers in a particular radius. That data is we have not updated that analysis in a while, but I think alone, just based on the CHAS data alone, we do have some provider issues, and people are having a hard time finding an office in their community. Thanks for the question.
All right, that's our only question so far. So
Wow.
if you have any questions,
Oh, thank you.
I think we have some rolling in. Can we get those in the webinar chat, please?
While we're looking for those, Sarah, your comments about, or the question about a provider issue. I'm curious if you could talk a little bit, maybe even expanding beyond oral health, about the work CHI has been doing to look at the oral health and healthcare workforce more broadly.
Sure. So we've been working with different partners, in particular, some of our partners, well, a few. So we have some of we've been working with the Delta Dental of Colorado Foundation and really supporting their grantees, and helping the foundation also through evaluation efforts. And one of their priorities is really around access. And so we have appreciated that partnership with the foundation, as well as the opportunity to be working with the grantees across the state on some workforce issues. Secondly, we've had some conversations with our partners, Dr. Patty Braun and Sheriff Flowerday at Denver Health and Hospital Authority. We've worked with them over the last couple of years. First, it started really exploring the intersection of health information technology and how that can really be a support for the oral health workforce, and really helping with coordinated care and communication between primary care and oral providers, oral health care, especially in those integrated care settings. And we're continuing to explore and work with communities to help understand how are we taking full advantage of, for example, all of the expanded scopes of care that we have done as a state over the last several years for our registered dental hygienists, or use of certain types of care that is now available to help connect rural and urban communities.
Thanks for making that pivot. It's an aspect of our work I get really excited about. So I just wanted to have an opportunity to share a little bit more of that.
Great. And if there's anyone on the webinar who is involved in working in oral health, please put your comments on this in the chat, because there might be others who would be interested in hearing what you're up to or other resources. So thanks for that.
All right, thank you, Sarah. We got some questions coming in. We have one from Kat Martinez asked, what is the relationship between discomfort in getting needed care and demographics like race and ethnicity? Are rural residents primarily white?
Oh, for substance use, sorry. Okay, thank you. So, Kat, thanks for the question. So we did not do that rural urban analysis. We didn't break down kind of the demographic profile of those of Coloradans within rural and urban settings. So that would be an additional analysis that we would want to do. So I wouldn't want to speculate in terms of for those Coloradans who live in rural settings versus urban settings, kind of their race or ethnicity and how that may or may not show up in terms of barriers to care. Certainly, I was on the West Slope last week at the Western Healthcare Alliance Summit and had opportunities to connect with many of our rural hospital and healthcare partners while out there. And, lots of the benefits of being in a rural community is really that close-knit relationship that people have with each other and providers. And that I think is a strength that for those of us who have lived in rural areas, I really appreciate. And when someone is struggling with substance use, stigma is real and it's hard, and it could mean a lot of things to have to talk to someone who maybe you are seeing in the grocery store and maybe you're going to church with them, and then you're also having to talk to them about needing treatment. So again, if there's anyone on the webinar who is from a rural community or is a substance use provider or any kind of a provider and wants to chime in the chat and respond, I think that's a great question too. Please do. Thanks.
Great. And then our next question is, how do we select and validate survey questions for the chats?
Oh, who wants to say that?
I could talk a little bit about that, and I can't speak to the very beginnings, the origin story of the CHAS, but I do know that we start with a set, there's almost like a national database of existing questions that are validated. So we use those as our initial source of questions. And when we're creating new questions, for example, we added a whole series about climate change this year. When we're creating new questions, we do start with those databases. Often we can find the questions there, so that's reliable, and they're also comparable because those same questions may be used in national surveys, so we can then compare. But there are cases where we may have a question sponsor or questions of our own where there isn't an existing set. So we do have to create those on our own, and we do try to do, I believe the term is cognitive testing on those questions. And I'll confess that sometimes we've created questions that we thought were going to be great, and it turns out they were a little more open to interpretation than we thought. And we can't quite use the data in the way we expected. Those are hard lessons to learn, but we learn them and we go back and ask the question better the next time around.
There's a pretty detailed methodology document on our website. So also I would invite anyone who just wants to enjoy that to please check it out.
Our next question is availability of the full report. Teresa, if you need help finding the report, my colleague Deanna can drop any of those links in the chat. And if you have any other questions, you can specify in the chat. Another question we had are there any efforts in Colorado to increase birth control awareness or responsibility in the male population? It's a great question, and I think it's something that we can definitely get the conversation started, especially with these new data points. Like I said, this is the first time that we have had a question on the CHAS about reproductive health, so I think it's a great start, and I'm not really sure if there are any efforts right now, but there definitely should be, according to the data. And then another question we have is, knowing that the funding is key to being able to administer the CHAS, is there any talk with existing or new funders to make the CHAS an annual survey instead of every other year? And during and after COVID, I think timely data became even more important in public health. While there are other surveys out there to fill the data gap between CHAS surveys, 2 years is a long time to wait to trend these specific questions.
Oh, we agree. Did you want me to answer that? We would love to do an annual CHAS. It is a lot of work. It is also a lot of resource. And we are in ongoing conversations with our previous sponsors and our ongoing sponsors about that, about whether we've even our amazing data and analysis manager, Lindsay, I know they have presented on these webinars before, is thinking about, even did some work, could we do something in the intervening years, maybe a smaller CHAS, but to be able to provide annual data in an ongoing way. It's always on the table. We're always going to have a conversation about it. We are really reliant on funders to be able to do that, though. I'm happy to talk and provide more detail if anyone has additional questions. And we are totally transparent with the CHAS and how we do it and how much it costs and all of this. So please reach out to me directly if anyone has any questions.
One thing I will add, and it's certainly not apples to apples, different sample group and different questions, but the main sponsor of the CHAS Colorado Health Foundation does also have the Pulse poll, and they do have some questions that are similar. So in the off years, if you haven't, I would suggest taking a look at the Pulse also, because it might be able to answer some of those questions you have during the off years.
And I think we're gonna unmute someone now to either ask a question or answer a question. I'm gonna pass it off to my colleagues to do that.
Hi, this is Mandy Ashley with the Aurora Health Alliance. Driving with littles, or not driving, I'm riding in the car with littles. So apologies if there's extra noise or reception issues. So the Alliance is working with community-based organizations to create a guide to low-cost oral health care that walks folks through, are you eligible for Medicaid? Did you know that Medicaid is included, or oral health care is included? And then if those options aren't there for the individual, walks through different options that, you know, have low payment plans, have certain languages at the dental offices, etc. In this transcreation, which is not just translating, it's making the language appropriate for whatever culture we're doing that with. It's really exciting work, but as a part of evaluation, we're struggling to figure out how to evaluate that. So I would love an offline discussion on how to go about that. But if there's any community-based organizations on here that want to connect, I'll put my information in the chat. I think the idea of transcreating rather than just translating is really exciting.
Mandy, awesome. Thank you. Thanks for sharing all of that detail, especially while in the car with the littles. And would hope that there is an opportunity for some connectivity between folks who are on the webinar and the work that Mandy and the Aurora Health Alliance is doing and has been doing on oral health for a long time. Also would love to connect about how the CHAS can help. It's one of the use cases that we know people are really tapping into the CHAS for evaluation and having kind of that reliable, trusted data that they know will be available to them in an ongoing way to evaluate programs. So would love to connect to see how the CHAS can help you, Mandy, and hope that this has maybe sparked some ideas or interest among others on the webinar today. Thanks.
Thank you, Mandy. Our next question is, what part of participants are military? And I don't know, I don't have any more detail about if we're talking about survey or.
I'm guessing.
Yeah, the CHAS does ask in one of the initial screening demographic questions at the beginning if a person is active duty or veteran military. And I just ran those numbers 3 weeks ago, and I wish they were at the forefront of my mind. But I want to say statewide, give or take, we were about 10% military or veteran. It's very interesting. Just a sneak preview of a brief to come. We looked specifically at El Paso County. And in El Paso County, it's significantly higher. I want to say more than twice as high. And I'm seeing nods from the back of the room, so I think I've got that right. So depending on the part of the state you're in, but it does represent military population, and we do ask about that, and some really interesting findings about military households coming next week.
CHASapalooza continues. And with that, I think we've reached all of our questions, unless anyone else has a final question for us. Oh, we have one more coming in. I don't see it. Is it in the chat? I think we might have a little delay. Thank you for bearing with us while we're trying our new live, but oh, here it is. Is there, we have 2 new questions. Is there any organization that is an umbrella for repro health? That's a great question, and I don't
I'm not sure, but I would actually invite you to check out the Caring for Colorado Foundation website. They have really done a lot of work, and I know there's a name for the initiative, and of course, I can't think of it right now because we are live. But I would direct you to the Caring for Colorado Foundation, and they will be maybe a place to start for that information.
There are a lot of smaller nonprofits doing individual work. The question that I'm struggling to answer is who would
Right.
serve as that umbrella, but there are a lot of grassroots organizations just doing a great job with education, outreach.
Oh, Repro Clap. That's what it's called. You see how it happens. Repro Clap Colorado, I think, is the collaborative that the Caring for Colorado Foundation is funding. And there might be participants in that collaborative listed on their website. It could also be a resource.
Our next question is, isn't birth control an essential health benefit? Can you talk more about the data on barriers? With that context, are the barriers based on preference of the method to individual or simply access to a covered form of contraception? That's a great question. And we asked two questions. We asked, the first one was about conversations, if the doctors had those conversations and asked about reproductive health. And then the second one was the access question, which was, were you able to access the type of birth control you wanted? And that was, I believe, exactly how the question was asked. So regarding your question, that was within the context that we are providing the data in. So we are providing data of people who did not access the birth control that they wanted or requested. And I hope I answered that full question.
The data brief online that you wrote beyond
Yeah,
is really
and it has a
informative.
lot more
Yeah.
information, dives a lot deeper
Yeah.
than I can remember at 8 a.m. on a Thursday morning. But yes, thank you for your question.
And I'll also flag that on our website, on the CHAS, we have many data workbooks that are available for download. So it is important, yeah, it's a good, if you're curious and want to actually look at some of the data itself. Yeah.
Well, I think with that, we've reached all of our questions.
Oh, okay, now we're warming up. I think part of the question was around reproductive health benefits as an essential health benefit.
Oh,
And actually, this kind of gets us a little bit into what we're going to be talking about over this fall, is how we're doing some sense making of some of what has happened in terms of federal legislation, Supreme Court decisions, and what that means for health policy. Certainly, reproductive health benefits was an essential health benefit. And then we had some Supreme Court cases that allowed employers to make some different decisions based on employers. So I do think there is some variability. We are not the experts in this topic though, in terms of reproductive health. And so I do think that there are some other trusted places who can help understand that. And I would also invite you to check out the website and really download the data. It's the first time we've had it. So there's so much to dig into, and then let's hope that we can continue to track trends. So, okay, I think we've run our course on questions, which means I'm going to keep going in terms of talking about what's coming next. We are going to take a little summer break as we do every year, so we will not have a Hot Issues in Health webinar next month in August. We want to give everybody a little bit of a breather. We know that everyone is going to be juggling back to school routines. Maybe Mandy is already doing that. But so we're going to take a break in August. We're going to come back in September 19th, 2024, bright and early 8 a.m. As I mentioned, we've got some big plans through the end of the year with webinars that are going to be looking toward the elections and really exploring the public health and policy impacts, again, of some of those federal moves that have happened, both with what we can be thinking about with elections, but also some recent Supreme Court decisions. I also want to tell you, we will have an update to share regarding CHI's annual in-person Hot Issues in Health webinar. Hot Issues in Health conference, sorry, I'm going to change that. So you are going to want to be at the September 19th webinar. So save the date, use the link or the QR code and register now. With that, I am confident that our team has put lots of links and information in the chat so that you can find everything and more on our website. Thank you for joining us this morning as always, and for being part of our inaugural audience for our office media studio. So if you ever want to come by our office and check it out, you are always welcome. Thanks, everybody, and enjoy the rest of your morning.